wonderful you stay calm. Okay. That's good.
Ready? All right, you guys ready? Everybody ready? All right, everybody, I think, can you all hear me? I usually don't need a microphone, but tonight I'm going to use one. And I'm actually going to take it out of this holder. All right. So we are so excited to have you here this evening. This is kind of a dream come true for me. I've been planning this with all of these wonderful people here for probably over a year now. So we want to welcome you to Mind Matters, Caring for Your Well-Being Through Cancer. I am Wendy Myers. I know a lot of you here. I'm a licensed clinical social worker and a senior clinical manager here at Cancer Bridges. I oversee the short-term supportive counseling, the support groups, and the bereavement program. I also wanted to introduce, because this lady is very special to us here, special to me. Her name is Bree Reagan, and she is a child life specialist here. She also is getting her LPC. She's earned the license and working towards being certified. So I wanted to, we're a community full of support for everybody in the family, and Bree, takes care of our family and youth. So I wanted her to say a few words.
Thanks, Wendy. So again, my name's Bree Reagan, and anything that we offer here for adults, mental health wise, we also offer for children. So any child that's impacted by cancer in any way, whether they are diagnosed or know somebody in the family that is diagnosed or a friend, we provide free counseling support to children and their families if family counseling is needed. And it's such a gem for the city of Pittsburgh because there is not any place that I know of that offers free counseling for children with a professional. So I'm going to leave my cards on the table back there. If anybody's interested and wants to talk to me, I'm happy to chat with you about it.
Thanks, Bree. So I also wanted to welcome our in-person members, but also the people online. We don't want to forget about them this evening because it's a really important part of what we offer here, to have a hybrid model. So we're really excited to have all of you here and those of you online this evening. So I want to introduce our wonderful panel. These are some of my most dear colleagues and friends over the years that I have been a social worker in Pittsburgh and certainly in oncology care. So we're going to go from this side of the table all the way down. And this is Robin Belpe, and she is our featured speaker tonight. So she's going to get up here shortly. She's the medical director for the Center for Counseling and Cancer Support at UPSC. And then next to her, we have Emily Cottrell. She is the clinical director for Integrative Behavioral Health of AHS. Next to her is Stephanie Brezinski, who is the clinical health psychologist at AHN. Next to her is our lovely gentleman. He's sitting in the middle of all these lovely ladies, right?
Is that why I'm in the middle?
Yes, yeah. We purposely
Sandra.
he possibly put him in the middle. Andre Plate, he is a clinical health psychologist also at AHN. And then next to him, we have Darla Timbo, who is from Atlas Counseling Service. So we're thrilled to have her here. She's a health psychologist. And then we also have Elizabeth Schandelmeier. She is one of our own support group facilitators for our brain tumor support group, and a grief counselor and educator. And then next to her is, one of my dear friends for a long time, Stephanie Samolovitch. And she is the founder and executive director for Young Adult Survivors United. So very proud of all the accomplishments that Steph has done over the years. And then last but not least, I've actually known Rita a long time as well. Rita Lampe, who is an LCSW, licensed clinical social worker, and she is certified Eden Energy Medicine Practitioner. So we have quite a wonderful array of people here this evening to talk to you about some really important topics. So I just thought I'd start out with, I have to put my glasses on because I'm getting older, right? To read all of these things. So just some words of inspiration and hope for this evening. You would know me, I think I have a pretty big heart, and I love to start things off with hope. Like, hope is just something important we all have to have. And so this poem I really loved. So, though shadows fall and fear takes hold, a strength within a story told. Each breath a victory, small and grand, a steady hand, a helping hand. The sun may hide, the storm may rage, but hope's bright light will light the stage. Remember strength you've found before, and open wide to life's warm shore. A tapestry of moments, dear, will fade away and hold you near. Embrace the joy in every day, and find your way along the way. This journey's path, though fraught with pain, can lead to sunshine, light, and rain. Believe in you, believe in all, and rise above, stand tall. So breathe it in, the hope so clear, and know that strength will conquer fear. With love and faith, you'll find your way to brighter days, come what may. So hopefully that will give you some hope and some inspiration as you listen to all of the great services and support that we have for all of you out there. Just a couple other things before I call Robin up here. When I thought about doing this, for the years I've been a social worker, which has been over 30, hard to believe, I thought about what are the three things that I kind of wanted to mention here before we kind of kick this off. And the first one, of course, is the stigma of mental health, right? May is actually, some of you don't know, but it's why you're getting all the green things in these little goodie bags, is Mental Health Awareness Month. And it's a really important month to be aware of, what are the things that we need to do to support one another and ourselves. So as a young social worker many years ago, I worked at St. Francis, and I remember going into patients' room and talking to them, and they'd share all this information about their fears and their worries of new diagnoses, right? And I'd say, have you shared that with anybody? Oh, no, Wendy, I couldn't share that because if I share that, they're going to lose hope or they're going to worry, right? And then I'd leave that patient's room and I'd walk into the waiting room and I'd see their loved one and I'd say, how are you doing? Oh, worried, I'm scared. I go home and I cry in the shower. And that just kind of broke my heart. And I said, well, how long have you been with this person? How long have they been in your life? Oh, 20, 30, 40 years. And I said, there's so much love to be had by sharing those feelings. And hope and fear can exist together, right? And so, those conversations are so important to have. And then just this week, I kind of got an inspiration. I was with one of my clients who lost her spouse. And he not only had cancer, he had bipolar disease. And she said to me, Wendy, actually the bipolar disease was harder on him than the cancer. He felt more comfortable sharing his cancer diagnosis than he did his bipolar. And that just broke my heart, right? And so I thought that was important to understand tonight, that we should talk about this and that we should talk about our feelings. And that's why we're all here tonight. So our wait lists are long. Every one of these people I know are booked. They have lots of patients and people they take care of. And even here at Cancer Bridges, we had 628 free counseling sessions in 2024. And it's just crazy to even think of that, right? So now many people do talk about their feelings and many seek help, but sometimes they're seeking help from a regular therapist, which is great. All of us would agree any support is better than no support, right? But what I put together with this panel and what all of us do is we do have a specialty in working with people with chronic illnesses, and specifically a lot of us cancer. And so I think when you're looking for somebody, it's important. I have a lot of patients that say, well, I have a therapist, Wendy, but I want to kind of see you because you know about cancer. And I think it is important, right? You wouldn't go to a cardiologist, right, if you had a broken leg, if you go to an orthopedic doctor, right? So when you have something that is special for mental health, you want to look for a practitioner that is specialized in what you're kind of dealing with. So it's important to kind of think about that. And lastly, the intention we have for you all this evening is to know that you and your loved ones are not alone. And having emotional support is a significant predicting factor in how someone moves through this journey. It's really important. To be alone is, you don't have anybody to share those feelings with, right? So you want to be able to share them with somebody and spend time with other people. So Jennifer Bridges, each of us will talk about where we are working. And of course, most of you know, and some of you may not know, that I've been here at Cancer Bridges since we merged 4 years ago. Cancer Bridges is one of your emotional support resources, as well as all the organizations that we have up here. Our mission at Cancer Bridges, we support those impacted by cancer who have a cancer diagnosis through a variety of free programs and services. This includes those with a cancer diagnosis, those who support a loved one with cancer, and those who have experienced the loss of a loved one due to cancer. And so some of our services that we have short-term support counseling, like I mentioned, 6 free sessions, either in person or online. And then we have, I think we're probably up to over 30 support groups right now with 43 trained professional facilitators, either nurses or PAs or nurse practitioners and social workers and LPCs. And we like to have a model where we have one mental health professional and one medical professional, and those groups really work well. So check out our support groups. We have education and community connections where we have, we bring in speakers like what we're doing tonight. We have panel discussions online on Wednesday evenings. We'll have different speakers for different topics. So, check out our calendar for those. Health and wellness classes. If you get a chance, we have a beautiful yoga studio up there. We have a Reiki room where we do Reiki and massage. So we have a lot of great health and wellness classes too. We have a train exercise, specifically working with people that have cancer. And so she offers one-to-one sessions as well as online. And it's just a wonderful service. Creative expression, we have a room up there called Matt's Makerspace where we do jewelry classes and drawing classes because sometimes it's hard to talk about all the hard things in our lives. And so it's good just to have an outlet. And there's a lot of research showing that if you do a lot of creative things, that your stress part of your brain will relax and your anxiety will decrease. So we have that available. Family and youth, you met Bree. She talked a little bit about that. And then we have some specialty programs too. We have a survivorship program that my colleague, Colleen Duardio, put together, a 9-week series looking at how do you get through survivorship and support through exercise and nutrition and emotional support. So it's a great program. Ken does Happy Feet, which some of you have attended, looking at 7 areas of things that you can control that I use in counseling. And she has done an amazing job over the years putting together speakers on each one of those pillars of wellness and then having a movement component to that program as well. And then the bereavement program, right? I know it's a hard thing. People don't like to talk about it, but it's important to talk about it. And we do lose people to this illness. So, that's something that was near and dear to my heart. So we put together a whole grief program, and we have multiple layers of that, including a Moving Through Grief series where we do educational topics around grief. And then we do a beautiful lantern event out at North Park with families and friends, and in the family youth program, Come With the Children. So a lot of great programs that we have, and check out all of our our website, and we're here for you. All right, so enough about all of that. So I'm going to move on to our keynote speaker here and give you a little information about Dr. Valpe. So Dr. Valpe graduated from the University of Rochester Medical School, where she focused academic interests on psychiatric care and community service for underserved populations. Dr. Valpe then completed her residency training in general adult psychiatry, as well as a consult liaison psychiatry fellowship and community psychiatry fellowship, all at the University of Pittsburgh Medical Center and at Western Psych. She is currently the medical director at UPMC Home and Cancer Center's Center for Counseling and Cancer Support, behavioral health clinic providing psycho-oncology services to patients with cancer and their loved ones. She also serves as the director of student mental health at the University of Pittsburgh School of Medicine, providing care for medical students during their training. She additionally has served as faculty in the fields of eating disorders, substance abuse disorders, and psychiatric sports medicine through UPMC with special interest in women's mental health, sexual health, and rural medicine. Finally, she has a passion for teaching medical students, residents, and fellows with specific focus in areas of wellness and burnout, and serves as a faculty co-chair of WPH Resident and Fellow Wellbeing Initiative. So we would like to welcome Dr. Robin Burton.
Thank you so much for that lovely welcome. I'm going to, so I have some notes here. So thank you for having me. Again, as Wendy said, I'm Robin Belby. I hail from UPMC. And I got recruited here. It was my second interview to Pittsburgh. I never thought I'd come to Pittsburgh. And after I interviewed it, I said, uh-oh, I think I'm going to be in Pittsburgh. And you can't make me leave, I guess, because I'm here forever. I love this city. I sometimes talk where I fell into cancer, into the world of cancer. And I won't look back. I absolutely love the work I get to do. And I'm so excited to be here to talk about this experience of weathering the storm, right? That dealing with the emotional aspects of cancer. I can't imagine a better way to talk about it than in Mental Health Awareness Month. Just to kind of piggyback on something Wendy said, I sometimes talk to my patients about how mental illness is a full-time job, right? And it takes up a ton of mental and emotional work on top of all the other things we have to do. And so I think, navigating this on top of cancer is a big part. So just to jump in, right. So when we think about mental health symptoms in cancer, it's important to know that this is really common. Among patients diagnosed with cancer, mental health disorders are present in at least 1/3. So this is people who meet criteria for a mental health disorders. Many others have subsyndromal symptoms. So they have symptoms that maybe don't meet full criteria, but that are really impactful. We also know that mental disorders are more common in patients with cancer compared to the general population. So if you have cancer, you're at a higher risk. But unfortunately, many of these individuals struggling with mental health symptoms go under-recognized and undertreated. It's estimated that less than 50% of cancer patients with psychiatric disorders are appropriately referred for treatment, which means those are people who aren't getting the care that they might need. And I think some of this might be that mental health symptoms can occur at any time in the cancer journey, right? And that sometimes includes when people aren't asking, hey, how are you doing? Are you doing okay? And I think sometimes that can be why this can be missed. So when we think about this, I think many folks with cancer feel that they have supports, right? Many of us can say that, many people will say, wait, I have doctors and other people on my team asking about my physical symptoms. They want to know about my nausea. They want to know about my pain, right? I feel like I have this team. How many folks talk about, I feel like I trust my team, right? And yet, our mental health struggles might go unnoticed, right? They ask me about my pain physically, but they don't ask about my pain emotionally. Or maybe we try to keep them hidden, right? Maybe I don't feel like I can share that because I'm supposed to be strong, right? Nobody can see that I'm struggling. Or maybe I don't even know how to describe it. Right? I just can't tell you because I don't know how to put that into words, right? And then in the midst of this, we are in a team, we're in a crowd completely alone, right? And I just want to say that in the midst of this, our physical health, or our mental health, is just as important as our physical health. And I like to say that if you aren't being asked about your mental health, I think that makes us think that it isn't as important. And I'm going to tell you right now, it is. It is just as important. So one of the things I was asked to kind of talk about is how do I know, right? How do I know if this emotional experience I'm going through means something's up, or means that am I one of those 1 out of 3 people who has a mental disorder? How do I know, right? So first and foremost, what I want to always say, using the storm analogy of cancer, right? When we're in the rain, even if we have the best umbrella ever, we're still going to get a little wet, right? I think it's important to recognize that everybody in this room can understand what it feels like to be sad, to feel like what it's like to be scared. I have an 18-month-old who I will talk about all day, right? He knows sadness. He knows fear, right? These are normal emotions. And sometimes those emotions, that getting wet in the rain, can happen at any time. It can happen in your oncologist's office. It can happen with a friend over coffee, right? Having these emotions are normal, and that's okay, right? And one way that we kind of talk about this is a term that is called psychological distress. Many cancer centers will give you a distress thermometer, right? And the whole concept here is that we recognize that cancer is stressful and that we have an emotional response. We have what we call distress with it. And that can manifest in lots of ways. It can manifest as fear or worry or being really emotional, crying easily. I talk about my bucket overflowing, right? Maybe it's I can't think straight. I have a hard time taking information in, dealing with information. Maybe I have trouble sleeping, right? And I will say we call this distress, but there's a lot of this that is normal and not to say expected, but it isn't something that gets people not necessarily worried. These are impactful symptoms. But how do we know that those symptoms have gotten worse to the point that it's a mental disorders? And the good news is we actually have very specific criteria that we look for. So this book on the right is our Bible within psychiatry. So the Diagnostic and Statistical Manual of Mental Disorders, lovingly called the DSM, or the Purple Book, as I sometimes like to call it. And what this book does is it just describes criteria for various psychiatric conditions, everything from major depressive disorder to obsessive compulsive disorder to post-traumatic stress disorder to even autism. So all of these things, why I like to say that is this isn't just a random collection of symptoms. These are highly studied and very kind of regimented criteria to meet. But one thing that unifies all of them is that when somebody reaches the point of having a disorder, is that it has this common feature of causing significant distress or impairing functioning, right? So, and I think about that. I like to say someone should reach out for mental health treatment if the symptoms are really getting in the way. So what does that mean, getting in the way? I would say, I first talk about persistence of symptoms, right? So I'm giving a talk today. Maybe I'm a little nervous, like when I wake up in the morning, maybe I wake up before my alarm. Maybe as Wendy's talking about me, my heart is racing, right? That's normal anxiety. If I was anxious all day to the point that I couldn't see any of the patients that I had scheduled today, that's impairing, that is too persistent, right? I couldn't do what I needed to do because of my anxiety, right? And so that might be. So symptoms that occur most of the day, most days of the week. And I love to ask this question of my patients: how much mental work, what percent of your mental energy went to your anxiety today, or went to thoughts about cancer, went to worries about cancer? If someone is saying 70 or 80%, that only leaves 20, 30% for the rest of your life, right? So that to me says that is getting in the way, right? We like to talk a lot about the non-physical symptoms that we deal with. Things like severe hopelessness or worthlessness. Or one thing I see a lot is intense feelings of guilt, feeling like it's my fault. Like I can't share my negative emotions because I'm so guilty that brings one of my loved ones who's rooting me on down. That's something I see a lot, right? Feeling so anxious that I can't concentrate, right? My worry thoughts, I cannot distract myself from these scary thoughts, right? That can be really tough. And another one I always like to ask is like feeling like yourself, right? Do you feel emotionally like you, right? The other thing we kind of talk about in terms of mental illness is changes in behavior, right? So if you notice that you're not acting the same, socially isolated, spending all of your time in bed, a lot of time, hey, sleep is great. Don't get me wrong. And especially when you're going through cancer treatment, sleep can be restorative. But if we're finding that sleep is a way to escape life, right? That's when we start to worry, right? Another thing to look for is how we cope with those negative feelings. One of the things I do like to ask people about is substance use or other things, other ways, maybe unhealthy ways that they deal with their stress. Is that getting out of control? If someone starts to say they're worried about, they started to increase their alcohol use. Maybe they went back to smoking, even though, their oncologist has really encouraged them not to. But that's how they have to deal with it. That might say, wait, is there something else going on that we need to treat? Right, go on, and that way. And of course, last but not least, we are going to talk a little bit about the thoughts of giving up or thoughts of suicide, right? And I will say this again, if you are having thoughts of suicide, please reach out immediately. There are lots of resources. 988 is the biggest immediate 24/7 geolocated help for if you're having suicidal thoughts. So there is support out there. Now, I want to say, as I bring up some of these symptoms, you're going to notice that a lot of those, how many of those kind of might make sense even if you're dealing with cancer? How many folks going through cancer don't feel like themselves, right? I want to say this is a complicated picture. I didn't put on that slide physical symptoms. There are a lot of physical symptoms we see in mental illness, right? Appetite, sleep, and energy problems are all symptoms that we see in anxiety and we see in depression. The challenge is for folks dealing with cancer, you might be having these because of cancer-related treatment. So that's what makes it complicated. Sometimes people going through cancer treatment feel hopeless because they really feel objectively like there aren't many options left. Is that them feeling depressed, or is that them kind of trying to face what's happening? And so I think in that way, this is why it can be hard. It can be complicated to identify mental illness because so many of us feel that, well, this is just because of my cancer and my treatment. That is one of the reasons why I dig in deep, right? When someone says, listen, I have no energy, but it's just because of my chemo, I might ask something like, if I gave you all the energy in the world, would you want to make dinner for your family? If the answer is no, like, no, I really just don't. I used to love to cook. I just don't want to anymore. That to me makes me worried about depression, right? That to me says something's different, right? And in that way. So going into that, I do want to talk about some of the symptoms that we talk about, that I talk about. And I will say, I only had like 20, 25 minutes. I can't talk about all the symptoms I ask about. If you have an eval with me, I am very thorough. I go through everything. But I wanted to talk about some of the big ones. So number one is the rainstorm of depression, right? So this, when you think about depression, once again, having a depressed or low mood in common, go ahead to the next. Depressed or low mood is very common after the stress of cancer, and it can feel very different from the norm. But about 25% of individuals require evaluation and treatment for their depression when it's kind of like a higher level symptom. And what we call this is a major depressive episode or like major depression. And I actually like to put, these are some of the symptoms that we might look for someone who's struggling with severe depression. So depressed mood most of the day, nearly every day, or a marked decrease in interest, not wanting to do the things you wanted to do. And then again, in traditional kind of major depression, you have 4 of the following symptoms that are listed here. Things like changes in appetite and sleep, change in energy or your movement, feeling workless, guilty, having difficulties concentrating, and of course, thoughts of death. For, to meet criteria, you have to have these symptoms for more than 2 weeks, and it has to be different from baseline. It also has to cause impairment. Once again, I want to point out that so many of these things might be a part of the cancer experience, right? So I think really it's about saying, I like to focus on the non-physical symptoms like that interest. Do you want to do things? Do you feel like yourself? The hopelessness, those kinds of issues are really big. And again, I want to point out one more time that it's one of those criteria is having thoughts of ending your life. And while in the midst of our cancer journey, death is often something that comes to mind, thinking about ending your own life is something that we can help you with, right? We want to help people get through those tough moments because that really can be a hard thing to deal with in the midst of the hopelessness that someone might be feeling because of depression, not because of cancer. And so please, reach out, seek emergent medical attention. I also want to give, just as friends and colleagues, another thought. I hear a lot of people say, well, I'm worried about my friend with cancer, but I don't want to ask about suicide because what if I make them do it? We have so much evidence that asking about suicidal thoughts does not increase the risk of suicide. If you are worried about someone, please ask and then stay with them and help them call someone if the answer is yes. If you're worried, please don't leave someone you're worried about alone. Next, I want to talk about the tornado of cancer. And this is my favorite weather analogy because I truly feel like anxiety is a tornado. I know when I have anxiety, it feels like a tornado. So anxiety is common in response to the threat of cancer, right? This is a threat. We are in a trauma threat response, right? We're worried about what's happening. And what we see in anxiety is a combination of both physical and emotional symptoms, right? We see in our mind, we have racing thoughts, nervousness, we can't concentrate, maybe we can't sleep. Our body also shows our anxiety, restlessness, tension. I carry everything in my neck, right? Shortness of breath, racing heart, dizziness, headaches, right? Some people get stomach issues, maybe a sensation in your throat, something like that. What's tough about, anxiety is I feel like oncologists are so great about asking about anxiety at the time of diagnosis, right at the start. But the truth is, anxiety persists throughout the whole time. Anybody heard the term scanxiety? Some of my favorite. Scanxiety, right? That anxiety that happens leading up to the scan. What about after the scan, before the results? Even worse, right? Just that, it's such a common thing. Anytime there's a change in treatment, right? Recurrence or spread. And one of the things I really want to emphasize, completing treatment. Everybody thinks we're ringing the bell, our anxiety should be gone. No, right? Sometimes that's when our anxiety is the highest, right? When our core is removed, when our treatment is ending. What does that mean, right? I also think it's important to note that anxiety can be caused by treatments, right? That anxiety as you're driving in to the cancer center, right? You're anxious as you're going there. But also it can impact cancer treatment. If I have fear of needles and I need to get blood draws, my anxiety is going to impact my ability. It's going to impact even me wanting to show up for my appointment, for my lab appointment, right? So I think it's important just to see that interplay. So anxiety is really big. Now for our last, the fog. And these are other daily symptoms that fog our lives, but that absolutely impact our mental health. Number one is sleep. Sleep is so important. And sleep issues can be difficulty falling asleep, waking up in the middle of the night, or waking up too early and not being able to fall back asleep. That's probably my biggest one, right? And it can happen at any time during the course of illness. And I think what's really hard about it is it can be caused by so many things. First of all, main criteria for depression and anxiety is sleep issues, right? So it could be from mental illness, but it also could be from the fact that our structures throughout the day is very different. Maybe we're not as active during the day. Maybe we're even napping during the day. So our sleep bucket isn't full when we're trying to sleep at night. Maybe we've lost our natural sleep-wake cycle, right? Because of the effects of cancer-related treatments, right? Maybe medications or cancer or other surgeries have led to physical changes, whether it's involuntary movements, whether it's something painful, rashes, burns, radiation burns, right? So many things can impact our sleep. And then also medications. What if we need medications during the day that make us tired, right? So that that makes it hard to sleep at night. Or what if steroids, I like to bring on, steroids are common causes of insomnia. And I think it's part of almost every cancer regimen, chemo regimen. So just something to know, so many things impact sleep. And that impacts our mental health, right? Then there's fatigue. So even outside of sleep issues, fatigue, cancer-related fatigue is a distressing, persistent, subjective experience of physical, emotional, and cognitive tiredness. And I like to emphasize it's all parts. It's not just that my muscles are tired. It's that my whole self is tired, right? And what we see in cancer-related fatigue is that it isn't proportional to activity. You can do almost nothing and feel incredibly fatigued. And it interferes with functioning and quality of life. The other thing is it can happen at any stage of disease. It's not just during active treatment. A lot of times people can see this fatigue persist on into survivorship. And then, of course, at end of life. Another one I get asked about a lot is brain fog, chemo brain, right? And I just like to give some numbers here that up to 40% of cancer patients will have evidence of cognitive changes before any treatment. Up to 75 will have decline during treatment, and up to 60 will have some of those ongoing declines, not further declines, but we'll see that deterioration persist after treatment. And so those are some of the numbers. Here is perhaps the good news is that most often it's mild to moderate. It's not the same as a dementia or stroke, but what we do see is deficits in processing speed. It's harder to do the things that you used to be able to do, and thinking-wise. And again, we also see some issues with memory, retrieval, and concentration. But I do like to say I call it cancer-related cognitive impairment because if changes are happening before you've had treatment, it can't just be chemo brain, right? It is related to cancer. It's related to all these cancer treatments, but it's something that absolutely impacts quality of life. So I think here, whether you are dealing with the rainstorm of depression, the tornado of anxiety, or the fog of sleep or fatigue or cognitive changes, what this is all about is finding ways to manage through the storm, finding our umbrella, finding our galoshes. And what we know is that what we need out in our specific storm is different for each of us, right? I'm an umbrella girl. Maybe you're a galoshes, or maybe a raincoat, right? And that's okay, right? Some people will need different treatments than you. Some people will need medication. Some people won't. Some people will find great benefit from movement and yoga, and maybe some people won't, right? And I think I like to say that what influences what works for us is very complex, right? We are complex individuals. We're influenced by our personal experience, our culture, our societies, that intersectionality of who we are, race, gender, socioeconomic status, and just what we believe. And I think in the midst of that, knowing that my picture or my storm might look different is okay, right? And so we're going to talk about what some of the supports might look like in our team. But before, just kind of thinking broad strokes, we have personal supports, family and friends. We have support groups, right? So sometimes that can be just an online community that you can post on Facebook to. Other times it's more structured. Cancer Bridges, Wendy talked about all the amazing support groups that are here. Organizational involvement. Again, we have some organizations that are going to talk about what they offer. Oftentimes organizations, they either come together because of maybe a specific cancer type, or maybe a unifying feature, young adults with cancer, maybe a specific symptom that they're dealing with. And what's great is not only do these offer support, but a lot of organizations offer opportunities for education, advocacy, lots of other things that can be very meaningful to someone going through this and can be an amazing support. And then we also have more formalized treatment, which can look like therapy and medications. And I'm not going to belabor this too much, but I do love this next slide because I think it is incredibly confusing, all the names of the different providers that are involved in mental health treatment. And I'm going to be honest, this is not inclusive. I just realized I do not have a child life specialist on here. I am so sorry. I don't have life coaches on here. Rick, there are lots of people that can provide support, so this is not exhausted, but I do like to explain just a couple quick things. A psychiatrist is a medical doctor who has completed medical school and then residency specifically in mental health, so specifically in psychiatry, and they can prescribe medications. A nurse practitioner and physician assistant has either a nursing or physician assistant background, often with some extra training within psychiatric field. They can also prescribe medications. The third group that can prescribe medications is what is called a psychiatric pharmacist. This is state dependent. Not all states allow pharmacists to prescribe. Actually, don't APA can? Yes, I was like, pretty sure it still can. But some states do, and they actually have a program for some extra training, a residency within psychiatric pharmacy, which is what I did read about. So that can exist. So those are your prescribers. A psychologist, also a doctor, but a doctor of psychology. So typically a PhD or PsyD. But because they're not medical doctors, they cannot prescribe. So they're going to do evidence-based therapies, but again, non-prescribing providers. Licensed clinical social workers, which can be an LCSW, LPC. These are folks who have usually master's levels training or above, who have done additional licensure, clinical licensure. So this is hours of clinical supervision to get a clinical license. We also have social workers who might not be licensed clinically, and yet they still provide a lot of support. I think a lot of our Hillman Cancer Center social workers might not do individual talk therapy, but they definitely do provide support. We also have other therapists, recreational art therapists, maybe who aren't licensed, who can provide that. Certified peer specialist is usually someone who's gone through the same diagnosis or situation, and they have gone through extra training to be certified to help support someone through a specific issue. For example, somebody who is in recovery from substance use disorder can be a personalized peer specialist for somebody going through substance use disorder treatment. That's different than a peer support that isn't certified. We see these a lot. Things of very commonly known peer support is like Alcoholics Anonymous, right? You need no criteria to be a peer support to your friend in AA. So that kind of thing. So that's just some of the roles. If we have questions, we can talk about that. But again, really, just generally what mental health treatment looks like. It might look like medications. It might be seeing one of those first three on there. But a lot of times it's individual therapy, or maybe it's group therapy, or maybe it's peer support. Maybe it's self-help. Maybe it's movement, right? And I think coming into this knowing that it's okay that it looks different, because the whole goal here is to see the clouds, like to see the sun come through the clouds, right? To make it through this storm. And that's why we're here today, is to talk about how we do that. So I thank you for your time and attention. I think I'm going to turn it over to the rest of this amazing panel that I get to be up here with. So thank you very much.
Thank you, Dr. Valby. That was fantastic. Very good overview of mental health, and certainly of what all of us do, which they'll all get a chance to talk to you about what, where they sit on that, that flow chart that Dr. Valby showed us, right? And of course, I love your analogy because my youngest son is a meteorology major at Penn State. So he will love that too. It's crazy. So a little karma going on now. So anyway, I'm not going to do any more talking. I'm going to let all these lovely people do the talking next. So we're just going to start with Dr. Cottrell and then kind of work our way down. So you each have microphones in front of you, so you can just share those. This way, guys. You can actually even move. You can even move it closer to you. Whenever you're doing it, you can use that. Okay.
All right. Better? No, not better. Right down.
Hey, better? Excellent. Thanks, guys. I'm not great at physics, so the angle, and no, you don't need to go to physics to be a doctor, so. Judo's Casson. That is a requirement. I'm Emily Cottrell. I am also a psychiatrist. I actually trained with Dr. Lampe. If the psychiatric community in Pittsburgh, everybody passes through UPMC at some point, either in training or to work of attendings. It's very true with all sort of overlap at various points. My background is also very similar. I came from a totally different state. I grew up in Kentucky, did all of my training and schooling there, came to Pittsburgh for residency, and never left. Just stayed. I've been here now 11 years. I am double boarded in psychiatry and family medicine. So I came to UPMC so that I could do a residency that allows me to train in both sort of what I'll call the mind-body interface. So I do primary care, physical health care, like a general practitioner, a primary care physician. And I am also a psychiatrist. So that part of my residency I did with Dr. Lampe. And then I left UPMC after I graduated residency and went across the way to the other place, Allegheny Health, and was able to do the thing that I love in my career, which is kind of stand up a program that provides behavioral health and psychiatric care for patients who need medical treatment. So I work in a primary care office 100% of the time. My hat just changes depending on the day. So I'm either doing family medicine or I'm doing psychiatry for primary care patients that are referred to me by the primary care providers. So I have, at the moment, 20 or so primary care providers who are in my little referral pod. I work at a pre-tree medical associates that happens to be my office. And I have 2 other offices in Crafton and the Robinson area. North Fayette typically is where the building is. Those are my people. Those are the primary care providers I work with. And it's a patient population of about, I'm going to say 12 to 15,000 patients, or even the whole catchment area attached to those 3 patients. So this is what I love to do. My passion in my work and in my life and in the way that I'm trained is to figure out how to integrate and marry the idea of the importance of mental health treatment for people that also need medical care. So I work with patients with all sorts of chronic medical conditions, including cancer. And I anchor to their primary care practice. So like wherever their primary care medical home is where, in my mind, that's where they should be able to access their mental health treatment as well. And we work as a team. I refuse to work in any other way. So I work entirely as a team. I'm not a very good private practice psychiatrist. I'd be bad at that because I like to work with other folks. I work with a clinical pharmacist as well, is phenomenal. I work with social workers. I work with therapists, primary care docs. We have a dietitian in our office. It's an awesome team and an awesome resource. What I'm trying to do is, as much as possible, expand this operation so that there are more me's, more psychiatrists which are entered in regions throughout all of our primary care footprint, as they call it in like corporate speak, at AHN. And I also work to my left for phenomenal nominating sources as well, specifically for cancer patients at AHN. So I will stop speaking and I will allow them to take over and tell you what they do, so you can kind of get a sense of the breadth of services we offer at AHN.
Okay, can you hear me? I know, Thelma.
Loud, you have to talk physics.
Yeah. All right. So I'm Stephanie Brezinski. I'm a health psychologist at Allegheny Health Network. I'm probably the newest person in Pittsburgh on this panel, though. Second. Hi. I got on our team, but you have this table. I just started here in September.
So I'm relatively new to the institution, but I'm embedded within the Cancer Institute. And so I'm primarily operating out of the Wexford Cancer Institute. And I provide individual therapy to adult cancer patients anytime from time of diagnosis and beyond, really any diagnosis of cancer. And so I primarily operate out of that clinic. And really my role, I see a lot of, as Dr. Valpe had talked about, a lot of mood changes, a lot of anxiety, things of that nature, adjustment to illness, adjustment to side effects, things like that. That transition from active treatment to beyond is a huge stressor for a lot of people. So I actually see a lot of people, even once they're done with treatment, which I think a lot of people think is the most stressful time, but then they get after the fact and they're like, well, wait a second. I actually expect it to feel better and not get worse. So I see a lot of folks at this moment kind of in that bucket. One, I say that to normalize like the transition from treatment to either maintenance where you're not going as often but still in treatment, or even just transitioning out being done. Doesn't necessarily mean that we expect you to just move on with your love but not need support. So if that's you, certainly I hope you get to learn a lot tonight of like what maybe some signs and symptoms are that you should look out for. Maybe you have an increased willingness of reaching out for support or for help. Trying to think if there's anything else that you mentioned, but yeah, anything you can think of that you would want me to mention? Sure.
You're good. Yeah. Thanks.
I'm gonna tell it to talk loud. At least that's what my wife tells me. So yeah, I'll turn it off. So I'm Audrey, please. I went to Penn State for undergrad. I'm gonna have to pick your brain about your son later when he went to Ohio State for my doctoral degree. I'm a Pittsburgh transplant. My wife had a big Italian family here in Pittsburgh, so I'd like to say I'd say in the matter, but I didn't have a choice. So I started off doing my fellowship here at Allegheny Health Network, and that was the first time I dipped my toes in the whole cancer world and fell in love with it from really day one. I think it's really rewarding and fulfilling to be there to support and help people through arguably the toughest time of their life. So kind of get a little bit of like the background of what I've done and where I'm at now. So I used to be over at West Penn Hospital in their medical oncology clinic. So I did a lot of outpatient therapy there with cancer patients. I also did some inpatient consultation and liaison work. So that's like patients who are admitted to the hospital and maybe they're like newly diagnosed. We had a hematology and oncology service there. So patients with like leukemia, lymphoma, multiple myeloma. They would come into like bone marrow transplants. We would provide support for the immune patient, which is a service I feel like people don't really know exists, at certain facilities. I started mindfulness for cancer therapy group while I was on fellowship there. But then I had 2 babies and I lived in the South Hills, so I wanted to make my life a little easier and have less bridges to cross in my giant York. So now I practice out of the South Hills, the Bethel Park. So she's daddy. I do actually have a job there. So I practice out of the Bethel Park Oncology Clinic. I would say a bulb of my day, 95% of my day is really doing therapy with patients. But I work in an integrated clinic. So we have oncologists there. We have nurses. Behind my office is our infusion suite where patients are getting chemotherapy. We have a dietitian. Who else? PA, physician assistant. So I do a lot of consultation, collaboration with our team there as well. Yeah, but really my passion is helping people on the therapy route. I'm a health psychologist. People don't really know what that is. So how I explain it to patients is, hey, I really specialize in helping people cope with the unique challenges that come with having a health condition like cancer. And I would say a lot of times people have other issues that they want help with in therapy as well. But some really common things I work out with folks, I would say anxiety is probably the number one thing. Fear of recurrence, fear of it spreading, fear to die, fear of the treatment's not working, sadness, depression, grief, you don't need to lose someone to grieve. You know, a loss of independence, a loss of physical functioning, a loss of the ability to work. Trauma, you know, medical trauma. People that face really difficult things in their journey with cancer. A lot of my patients have prior trauma that they're dealing with as well, and then this is just bringing a lot of that to the surface. Insomnia, difficulty focusing, you know, dealing with all the physical side effects and changes, you know, adjusting for life with cancer. It feels like your life can like flip upside down completely. So a lot of it's just kind of learning how to, you know, adjust to some of that. I really pride myself on like teaching patients action skills that if you use to cope and work through this stuff. It's really sad. I get a lot of patients in my office who have been in therapy for like 7 years, and they're like, I love my therapist every week. It's great. It's super helpful. And I'm like, so why are you still going? Yeah, so I really pride myself on like, I want to teach you to become your own therapist. I want to empower you to learn that you could actually do some things differently to cope with some of these things, you know, and learn how to weather the storm. I love that analogy. Totally stealing that. Yeah, so that's really what I do. You know, and I think it's important to provide evidence-based therapy. You touch on like evidence-based therapy. It's scary out there what a lot of therapists are doing, you know, and then that's why people get stuck in this run being therapy, or it's not helping, or they're stuck at therapy for years on end. So, you know, I really want to provide therapies that are grounded in science and research. If you come in and you're willing to do some work, we have the science showing that these therapies can actually really help you. You know, you would never, ever take a cancer treatment that wasn't backed by research. You know, make people try like homeopathic stuff as an agile treatment, but yeah, for a primary treatment, people want like, hey, give me the best treatment, but they don't always do that with their mental health. So I'd really pride myself on, you know, providing evidence-based therapy, which is why I recently just got board certified in behavioral and cognitive psychology. So that's like CBT. You've heard of cognitive behavioral therapy. That's like the gold standard treatment. So that's what I do. I really would just cash. And I do a lot of this too. Community outreach. I get asked to give lots of talks and presentations, just even outside the cancer world too. You have AHN, Highmark, and so forth. I feel like we're rambling. What did I miss?
No, you took a great job on it. Excellent. Thank you.
Happy to be here.
Hi, everyone. I'm Darla Timbo. As I'm listening to everyone talk, okay, remember say this, I have to say this. Don't forget this. So I am the owner of Atlas Counseling Services here in Pittsburgh. I'm not a transplant. I am born and bred here in Pittsburgh. I've lived other places, but it's how it came. So up here, I work extensively in the community. So my office is located in East Liberty. I work throughout the community in all of my years in psychology and mental health. I also teach at Penn West, California campus. So I teach in their psychology department. So I'm getting clinicians ready to go out and do some of this work, a lot of this work, and kind of work, you know, in the community with the folks. What I typically do in a private practice is I work with a ton of clients that are caregivers. So I, you know, had over the past 17 years, I've been in private practice. I've had a lot of clients kind of present with a cancer diagnosis or some other pretty significant illness, but who I tend to see a lot of is caregivers, people that are caring for and loving people, you know, struggling with cancer and mourning for these different diagnoses. I work with a lot of women, and I work with a lot of women of color, a lot of Black women. And then I was telling my colleague here that I work with a lot of people recently released from incarceration, and sometimes they're kind of forgotten population. A lot of people in jail are struggling with cancer diagnosis. A lot of people in jail have come out and you're still struggling with like grief and loss of things, you know, physically and health-wise that have happened while they were incarcerated, or to their loved ones while they were incarcerated. So I see a lot of folks, you know, that are kind of going through some of those things.
I don't know. I'm trying to remember. I'm trying to think what else I want to kind of put out there. I do a lot of talks, a lot of workshops, a lot of presentations and speaking engagements around uh, caregivers, mental health as it relates to caregiving, and I do a lot of somatic practice as well. So I was trained at Carlo, received my doctorate at Carlo here, and just kind of, graduating from that program and thinking about like what it is that I wanted to do, what I wanted to put out there. There's a lot of stigma in the Black community around mental health in general, and not reaching out for sports, not reaching out for the types of things that we all need. So what I do in my practice is combine with two. So we do some evidence-based treatments, as you heard about some of those. I love the science that backs what it is that we kind of go through, how we process things. And okay, here's the science to help us kind of get through that. But also there's the science that we hear and we learn about that's evidence-based, that has to do with our body and how we manifest kind of traumas and grief and loss and all of the different things throughout our body. So I combine the two. So someone might come to me for therapy. I'm using an evidence-based practice. And then, I might do some, deep breathing. We might do some other somatic practice that's associated with yoga. I run a sister circle in the community, and all different types of women come through the sister circle. We do a lot of somatic practice there too. And what I find, it's even, for example, with the sister circle, I am not using an evidence-based practice, and we're using more of historical kind of cultural model that's not really, science-based. It's not backed by anything but history, which is pretty important. I see a lot of come from that too. And the Bio women really enjoy it. They come back. I know they're receiving something that, they may not be receiving in a kind of community setting. So I'm happy to be here. I think this is wonderful. I'm super excited. I love hearing everyone and kind of talking to everyone, and you would get some referrals.
Thanks, Darla.
Hi, I'm Elizabeth Schandelmeier, and I'm the first of the not doctors who are on this table. I'm a licensed clinical social worker. I do have my own small private practice, how in my grief support that is exclusive to death, dying, grief, loss, chronic and terminal illness. As what you mentioned, I do also facilitate the support group here for people with wing and brain tumors, which is a group that's near and dear to my heart. I've been doing it for maybe 7 years or so. It's been a little while. And then during the day, I work for UPMC Family Ascus. I'm a senior bereavement counselor, and work with families. For me, provide 15 months of individual counseling after death, but I also remember families before the death, and I can work with the folks who are dying as well. So before in that position, I was on the palliative team at UPMC Presbyterian Hospital, where my role was to support folks through their hospital experience. And if you're at Presby and palliative team was working with you, then there's probably been pretty long. It's what you're moving through. So that is where I really started to begin my journey of working with folks through chronic and terminal illness. And one of the things that is so impressive to me about this panel, but also Cancer Bridge, is it's one of the few spaces that I'm aware of that really helps people, support people through from diagnosis, through treatment, through end of life, and also through bereavement. And that's a space that I call the continuum of grief. And when you're in the hospice world, when I'm working with families before a death, for the patient's circle of support, and I say that intentionally because I want folks to understand that we don't have a requirement for this thing that we call, family. We allow families to define for themselves what family means to them. So when the family's supporting a person who's dying, they're often experiencing what we call anticipatory grief. And we think of that as this part of end of life when people are anticipating the death of somebody that they love. or somebody that's important to them, or somebody who is significant to them, because it's not always a relationship that's based on love, to be perfectly honest. For the person who's dying themselves, I describe that as preparatory grief. People are preparing themselves for the death. I was doing a podcast for UPMC Health Beat during a cruise, and we were talking about some of this space, and I found that we started talking about the area between sort of diagnosis and sometimes before, because I've certainly encountered plenty of people who have hesitated to get a diagnosis when they're fully aware that there's something terribly wrong. So sometimes it's diagnosis, sometimes it's before. Through that space of diagnosis and treatment and working to move through the medical system before you're reaching end of life. When I was doing this podcast, I found myself describing that as a gray area. But after the podcast, I was really, I was really concerned by the words that I used, because the people that I work with who are moving through that space, their life isn't gray at all. Their life is pretty remarkable. And rather than focusing on death and dying, what they're really focusing on is living your life as well as they can, as best as they can. And so I'm working with this idea that we call twilight grace. And that is this space that's sometime in between the brightness of day and the darkness of the evening. That's sort of glittery, kind of beautiful. We don't really know when it begins. We don't really know when it ends, but it has some pretty special moments. And sometimes it's also characterized by melancholy. So this is a space of grief that I've been doing a lot of work in. And I like to put words to it because I find that people who are moving through that space often don't know how to describe what they're experiencing. And we often are hesitant to use the word grief because we associate that with death and dying. But grief is actually a very human expression of loss. And when people are moving through treatment, there can be a lot of losses that are occurring. And maybe losses to your physical abilities, and maybe a shift in your identity. I've not met a single person who has been diagnosed with cancer who doesn't mark their life in before cancer and after cancer. Just the changes that occur. And often in that space, people are also comparing their before life to their now life, and often describing or thinking of themselves as having a deficit rather than simply a transformation into something new and different. And so I think that when we start to be able to talk about this space that many people are moving through in their cancer treatment, and we're able to put some work chat and help to normalize the experience of grief, that it can really help to supplement some of the other services that we've already started talking about. Grief in and of itself is not a mental health issue. However, it can stir mental health issues up. That's for certain. And RAFE is, I consider it to be very much in stress response. And so if you're struggling with anxiety, and grief on top of that can really put things, create a situation that's really uncomfortable. And so I would always encourage folks to seek out support from multiple different providers. Each of us provide very, very different perspectives. I did not provide medication management, for example. But that is not because I don't believe it. It's just that that's not my specialty. So I really encourage folks to especially if you're moving through cancer treatment, and having a specialist in what kind of medications might help and work with the treatment that you're having yourself is really extra important. So I think that's all I've got for now. Great.
How's my boy? I'm also a loud talker, so. I am a Pittsburgh native. My name is Stephanie Samolovitch. Who remembers Century Free Mall? I grew up like 5 minutes from there. Let's leave it at that. I also went to California University of Pennsylvania. So when you say, where? But again, my name is Stephanie Samolovitch, and I have to start by saying that I wear a few hats. Which is a little bit unique to the panel tonight, I think, because while I am the founder and executive director of Young Adult Survivors United, I think you all need to understand that this came from my own personal leukemia diagnosis in 2005. I turned 20 years old after my diagnosis and then quickly opened my eyes to why young adult cancer is so unique compared to kids, teens, and older adults. So I've been on a mission for many years to not only find others who could relate as a young adult, but to also build a community and a space and place for this population. I have a master's in social work degree, which I earned in December of 2010 from the University of Pittsburgh. I was meant to be a pharmacist, quote unquote, until I was diagnosed. So I changed my major just on the purpose of being in the oncology space and trying to build a young adult cancer community to the point where I did that between 2012 and 2018 through facilitating support groups. And through those discussions, I learned very quickly, even experiencing firsthand, like I said, that support groups were great. It's a place for them to connect with one another, to share their thoughts and their feelings. But there's also a population who are diagnosed between ages 18 and 45. That's who we support. So imagine their lives in your 20s and 30s. They're watching their peers get married and have young kids and be first homeowners and start their careers. You know, you're transitioning into adulthood. You're finally being independent. And then cancer comes and it all sets you just back and it completely disrupts your life during that time. So I said all that because I started thinking that they needed to get out of the house and they needed something to do where they didn't have to talk about cancer. And I love Cancer Bridges so much because there's so many opportunities where you don't have to just sit in circle and talk about cancer, even though you're surrounded by people who understand. That's the common denominator. So I built the model, which is the mission now for young adults who are represented, of providing emotional, social, and financial support. Because this is a population that doesn't have the financial security when they're diagnosed. They haven't been working very long. They're finally paying their own insurance premiums. So when cancer happens, it really hits them hard as far as that. A lot of them already have that, let's face it, from just a college, graduating from college. So I see a lot of them struggle with transitions. And so we support them from diagnosis and beyond. And a lot of times I see a lot of them come when treatment ends because they don't know who they are. They can't identify as themselves as they were, as we've talked about with the panel so far. They don't want to go back to their jobs. They do have young kids, and they're all just struggling in so many different ways, but in a way that they all can relate because it's the same developmental stage in their life. So I think it's also important to say that we were talking tonight about the beauty of COVID, because it has been a blessing for a lot of us, because before COVID, I don't think any of us in this room would have been excited about a virtual support group or a webinar or a counseling session. And now we have that as a convenience. I launched YASU, which I say is an acronym, March 1st of 2020, and then the pandemic happened 2 weeks after. It really challenged us, but it was seen as a blessing in disguise because, and you're on Pittsburgh, maybe you don't want to cross a bridge to go to a program. You can hop on from the comfort of your own home. So we provide both. We have virtual programs such as support groups. We also have in-person support groups at our office in Wexford, just down the street from Wexford Hospital. We also have the social activities. So this includes education and wellness. Some of our socials are most popular. We'll send paint supplies home. We have painting classes virtual. They love virtual video. They love virtual hot tea tastes. So simple things, but again, it's combining them all together and distracting them from the everyday stress. Some of our in-person socials are also very popular. We have a potluck Thanksgiving dinner every year. We've been doing that since 2014. We're still carrying the tradition. They bring their whole family, so a lot of times kids are running around and far all on the dance floor. So we've really tried to think about the whole entire family when we can. Pirate games come out this summer. We also offer financial assistance, and that's a big priority of ours. Knowing that not only financial assistance resources are scarce, not only in Pittsburgh or the region, but across the United States, especially for young adults. And so we provide help with rent, mortgage, utility bills. A lot of them just need help making ends meet. So we'll provide grocery and gas gift cards. We work a lot with cancer centers that provide integrative oncology services. So, for example, Hellman has their wellness suite. Patients can get free complimentary services. Let's say for acupuncture, we can now fund 5 additional ones for free, so they don't have to pay for that cost. Even something as simple as, ladies, and someone you might know, I'm not one to assume, but microblading services, it's like a tattoo for your eyebrows. And so with physician approval letters, they can now get free microblading, and that costs $500 to $700. So there's a studio on the South Hills we partner with. They can refer our members to for free microblading. So the testimonies you see, they look in the mirror and they don't have to pencil eyebrows on anymore, and they can just wake up and go. It's the little things like that that make a big difference sometimes to boost your confidence and really help it with your self-esteem. We have a program called Ray of Hope. A lot of people see it as an adult Make-A-Wish. A woman named Ray Leadings, my dear friend, she passed away at the age of 32 in 2021, and we now, out of that, have a program called Ray of Hope because her name is Ray Leadings. So this offers free respite trips for our members. It is a memory maker. It's a chance for them to just have respite, take a break, recharge, and it's a mental health relief, right? All of this to say it all is going back to us trying to enhance the quality of their lives. So everything we provide, I'm a huge mental health advocate. I see mental health equally as important as physical health in any space or capacity, oncology or not. So I really appreciate Cancer Bridges having this event tonight. I said to Wendy, I hope there are more opportunities and talks in the future about mental health because it's not talked about enough. And just you all being here tonight speaks volumes because you see the importance of it as well. So whether you're a young adult or not, I say always, find someone you could confide in because we all have unique experiences, but find others who are in your community, are in your space, are in your support circle. So if you need information, we do have a table over there with brochures and flyers. We do require people to register as a member before joining our programs, and we also have the caregivers in everything that we do. We don't have programs for kids because Cancer Bridges does it so well. So we don't take a lot of requests on here. So I appreciate the opportunity, and I'm going to pass it on to last but not least.
Thank you so much. It's an honor to be at this table with so many amazing practitioners and to be last and be able to kind of say something very different than what other people have shared. I'm Rita Lampe, a licensed clinical social worker. I'm also in the Eden Energy Medicine Practitioner, and I'll explain a little bit more about what that is in a minute. I also have been doing a monthly webinar for Cancer Bridges for, I think, 7 years ago, and that Wendy graciously invited me to do after understanding and participating in some of my classes on Eden Energy Medicine, how that can be helpful and integrative in my holistic wellness. And the people that showed to that were absolutely love it. It's very practical, it's very hands-on, and piggybacking on what Andre said, it's about teaching folks what they could do for themselves. Very, very specific skill, practical SMAG skills to help with the fight or flight, help response to the body that happens all the time when you're going through whatever you're going through, helps manage the nervous system, help people work on managing emotions, and so many other things. So I got into Eden Energy Medicine because I was originally trained in Reiki many years ago, early 2000, and it didn't really take that anywhere, and it wasn't chambered more, and I kind of just, universal energy brought me into finding Eden Energy Medicine, and what I did, and I started studying it. I went for 4-year training, which is very deep and very broad, and it's based on traditional Chinese medicine, integrated more with therapeutic touch. So it is a hands-on modality. I opened my own practice in 22 after being a clinical social worker for years in group practices. And one of the reasons I got into the energy medicine work is because I saw a lot of sick people, mental health-wise and physical. I got into working with people with a lot of chronic illnesses, including cancer and autoimmune. And talk therapy wasn't really moving them through spaces to places of more wellness. So when I found this alternative modality and I saw that it was working for myself, because I really got into it for my own wellness and my own physical pain that I was having at the time, and I started integrating into our practice because although it's a hands-on practice, and as a practitioner, I do work with the people that come in like a massage table, fully clothed. There's also ways to teach people to do things on their own. That's why the webinar I do is all, I'm teaching them how to work with their whole body's energy systems. And anybody's heard of emotional freedom technique or TAPI, which is under the energy psychology overall, this basically is that, and it falls under that too. So David Feinstein, who's a big guru in energy psychology, is married to Donna, the developer of Eden Energy Medicine. Came out of her own working towards her own wellness. She was pretty sick from a childhood allergies and tuberculosis and an MS at 16 and the hard crack in her 20s. This woman had all that, and then she had a breast tumor in her 30s and went away. She lived on Fiji for her own wellness. Said I needed to away, just be a space of calmness and eating organic food. Came back and was introduced to therapeutic touch, and then started studying this and evolved deeper, broader, the beautiful sacred work that she has and that I now practice. And I feel it's an honor to work with. I work with lots of folks with cancer. Over the years, I've been doing this. In fact, one of our whole weekends in training in our 3rd year is solely on cancer and what I learned from working with folks with cancer, how to help them. When I've been so bored than anything, and I think you said it quite well, is that, improving quality of life. Maybe not the quantity. Sometimes I've had many folks I work with who have passed away. But during the time I've been working with them, they're so appreciative of the space to be held, to be nurtured, to be heard, both in the therapeutic way as a therapist, because I'm honored and privileged by have therapeutic background to integrate with this wellness, holistic wellness with Eden Energy Medicine. And things come up for them, and they share them, and it's a healing, and it may not be a physical healing, but it's an emotional and it's a mental health healing. Sometimes it's to the part where they've been able to go home and share something with their partner or their child that they didn't feel like they could share before, because it opens them up. It allows the body's energetic systems to calm the nervous system, to ground themselves more, and to be in a space where they feel less fear, but less anxiety. So yeah, I work a lot with people with all those things: anxiety, depression, sadness, grief, and loss. But I feel like what I offer them is a way for them to feel more power, to take some of their wellness into their own hands. Going through cancer treatment and any long-term chronic illness, and I've had issues with myself with that. You feel like you don't have a lot of power. Going from one physician to another physician, and being told this and being told that, where these modalities that I teach to you, these practical skills, I've had clients tell me, I had my surgery and I was practicing some of the capping that you taught me, holding some of the things in my body to help my nervous system calm down or help me feel better, you just breathe. I'm using Referer. And the nurse came in and said, "What are you doing?" And I said, "I'm doing my exercises." And they're like, "Well, keep doing it because it looks like you're doing pretty well." So even though it's not super well known yet, like the term Reiki has been very colloquially known now, Eden Energy Medicine is becoming more well known. For me, it just integrates really well with what I do because it's so deep and it's so raw, and I feel like I can really. It's very unique. Everybody's different. Every session is different. Everybody's energies are different from day to day. But once you learn that you have the ability to manage your body's energetic systems, as well as your nervous system and the health stuff, emotionally regulate, I've watched people be able to manage and navigate some of these really rough times much better and be able to share on a deeper level with me, but also with their loved ones, some of the feelings and thoughts that what they need. And so that's what I do. I have a lab practice in Allison Park. I have some brochures back there with my card. I also left you 2 articles. So, people are talking here a lot about evidence-based training, and I believe in that as well. Those are articles written by David and Donna about more case studies of what we've observed and how this work really helps people. There's about 25 there, so I don't know if there'll be enough for everybody who wants one. There's also 2 books back there, Donna Eden's book on energy medicine and a book by one of my colleagues as an advanced practitioner as well, who also experienced her own diagnosis with cancer. And so it's kind of her own story about how she managed and used these skills to help her manage her full treatment. And so I stand here fully, and a lot of people think, I'll talk to medicine people don't support traditional medicine. Absolutely not. We see ourselves working very much complementary together, supporting one another for the holistic wellness of every single person. So her book is really about that, how she, managed her symptoms, helped her pain level, helped her manage herself, helped her manage her chemos and reactions better, using the stool sharing knew. And it's so those are back there for you to look at. Anyway, I also want to thank Cancer Bridges too, because it's an amazing organization, and I'm just privileged to your part.
Thank you. Thank you very much, everyone. Wow. I'm going to steal my tagline from Jen Kem, where I'm going to call you all my rock stars, right? She always says that, all mental health providers are rock stars, and you all are. And and you all have a unique skill set and, set of, education, and but we all combine together and we support one another, right? And I think that's what's important. So now we've done a lot of talking, right? And now we're going to open it up for all of you to ask some questions. So we're going to have people, and those of you online also can send your questions in on the chat, and then we will take those questions and we will ask the panel as well. So I'm going to open it up. Who would like to, who has a question? Comment, question? Okay. Oh, we have multiple ones. I saw Tekla in the back first, so I'm gonna come around and I'll get you, Carol. Go ahead, Tekla.
So about the baby, I would army be
Done.
you shall see. I am the young adult institution. He's also my side. And I don't know if this is a subset states, but R6 is constantly re-traumatized for me. So when I hear so PsyD, like sister or relaxation is something that happy to do the cycle all the time. Or self doubts. Nah. I like to say with hard work, I now suffer from headaches.
Yeah. Let me first need to take a step back. One thing I have learned treating and specializing in a world of cancer is that it is a really long journey. And there's a lot of things that come up along the way. And I think humans do also need ongoing support. And sometimes people need that. The place that's coming from is really power of people. Just knowing that you can actually learn how to do something to work through that. It is re-traumatizing. It brings up lots of different emotions, thoughts, feelings, memories that are difficult. So if anything, I was saying that not to say like, hey, don't get support if you need it, but really coming from a place of empowerment. And that's what I tell all of my patients is that even when we are being re-traumatized, maybe you hear about someone passing or something happens personally, and that's re-traumatizing, right? Because having metastatic disease has additional challenges that maybe non-metastatic disease doesn't have. It's to empower you to just know that you can actually learn how to do something to cope with that, to manage that in a different way. You kind of know it might come up, right? You might know that some of these thoughts and feelings are going to show up, and it's more about learning how to actually work through that in a more helpful, a more skillful, a more effective way so that it doesn't keep you stuck, having it like interfere with your life, causing a lot of distress, causing a lot of functional impairment. So I certainly want to advocate if people need ongoing mental health support. I absolutely advocate for that. And I have patients on my caseload who I have been seeing for, well over a year, or even 2 years, or they come back to me a year later when their cancer has come back. So I really, I want to apologize if that was, maybe a comment that, maybe was, you came out wrong. If anything, I want to reframe it. It's to come from a place of empowerment that, we can all learn how to do something that life is more for all of us, and especially for people with metastatic disease. So it's really about, learning how I actually work through this, because I know how challenging it is. So I empower people, including yourself.
If I can add to, and I realize I didn't talk about that my specific clinic at Center for Counseling and Cancer Support, but our clinic at EPNC serves individuals that are treated at EPNC Family Cancer Center and their caregivers dealing with cancer-related issues. And we're entirely an outpatient clinic with 2 part-time psychiatrists and up to 8 therapy providers is the maximum we've had. And just to jump right in, I have patients that I see today that I saw when I was a fellow in 2017. So I've started to see people a long time. I also really want to thank you for bringing up something I didn't mention in the slides, which is post-traumatic stress
symptoms. I thought about bringing it up because it's actually incredibly common. I think people think of PTSD, they think you have to be a soldier who went to war. That is just not true, right? We have a lot of folks with what we call post-traumatic stress symptoms or PTSS who might not meet that full criteria, pretty high threshold criteria for PTSD, but struggle with PTSS from their cancer because cancer is traumatic. I love the point you made. It is re-traumatizing. Every scan, every visit. And that is something that we absolutely treat at that impacts our storm 100%. So I just want to thank you for bringing up something that I think a lot of folks, I think the rates of official diagnosis are in the 10 to 15%, but up to 30 to 40% of individuals have PTSS. But of individuals with cancer have PTSS that is identified. So just something very common as depression and anxiety.
Just to piggyback on that, like I tend to think and to know, okay, disrespect to us soldiers, but they come out. Oh, we don't come out. We stay in that space. So it's hard.
But I will turn it over to into piggyback as well. I'm a metastatic breast cancer patient for going on 40 years. So I'm out there like survival. And through the years, I've gone through, different phases. Not always in therapy, but like as each phase of my life comes along, now I'm a grandma. How close do I get to my grandkids knowing I'm going to be something? All of my friends that I've become close with have yelled past. Why am I still here? What is it? It's luck, obviously. I don't know. My body loves the chemo, but I don't know. But if there are phases, then, I probably should be in therapy for because each phase, I feel like right now, like I said, I'm struggling with survivorship and, I now have grandchildren. What do I do? How close do I get to them? Like there's like a little bit of a wall up, and I feel that. And I'm like, why? So, I know what you were saying. Like I would never want to be stuck in the spot, but there are different phases in the life that you to help with.
I just want to speak to that too. Certainly, it is certainly support everything these guys are saying, and in my own practice as well with the metastatic population, it is new, right? Years ago, people either they survived or they passed, but now people are living with it, right? And that puts a huge strain not only on the patients but on the family and the whole system. So there is something in place for that. Like Tech was saying, there are times where we want to be like Andre saying, we want to empower you so that you do make this a piece of your puzzle, I always say, right? It doesn't define you. And so we give you those skills and then I let you go, right? And then you don't see me for a couple months, but knowing that I'm only a phone call away for an appointment and that even if it's just a light transition, right? Or if you have a recurrence, you can call me. People will say to me, well, Wendy, is this it? Like I can never call you again. And I said, oh my goodness, no. That's what I am. I'm here to support you on whatever transition you're going through because it's grief, right? And like, Elizabeth said, and we've talked a lot about grief is throughout our entire life. They're happy events. You define grief as any change in a familiar pattern of behavior. And so when any of those things change, we have to be there to be supportive and to give you new tools for your toolbox.
To be vulnerable about my own mental health. My inner critic is so loud right now. It's being this, I feel a lot of guilt and embarrassment. It's crazy. Here's another thing I want to mention too. It's not just about empowering, but when I was talking about like people being in therapy long term, like I think it's important to also ask yourself, like, what am I getting out of this? And I think a lot of the patients I was referring to, and I made that comment, are people who are just going to a therapist and they're talking about their week and they come to me and they say, I didn't actually get anything out of it. I felt like I was just talking and the person was just listening. Well, then that's how they get stuck in this rut of being therapy and they hit the plateau. So I think that's what I was referring to as well. If you're getting something out of it and you're learning coping skills or you're you're getting, support, and yet you're processing and you're learning ways of working through that, then that can be really helpful. There's nothing wrong with being in therapy long term. I also have patients who use therapy as the 1 hour a week that they talk about this, and it's like, that's how you get your emotional support. To your point, there's phases, and this is a long journey, and you also need to learn how to get, if you're just coming to therapy for like emotional support, to have someone to talk to, well, that's where you also need to learn how to build that support network outside of just coming in for 1 hour a week with a therapist. So those are just a couple follow-up points that I hope maybe kind of, get some corrective feedback, make sure that's helping, make sure you're getting something out of it. It's not just someone that you're talking to and they're listening and, kind of nodding their head, because that's not going to be very helpful either. Unfortunately, patients do tell me that that's what their therapy experience has been like.
You have to work on yourself.
Oh yeah, therapy's work. And it only works if you work. Yeah.
Just very briefly, a little comment here. As a person who prescribes mental health medicine for a living and will always have a job, like I'll always have job security, I would prefer it if folks were willing to do that work as compared to putting a pill in their body every day. Now, some people need both. They're tools in our tool belt, right? And there are certain illnesses that are relatively rare in mental health land that do require medicine, that I call medicine dependent illnesses. Those are not the common ones, though. They're not the common reasons. We're talking about depressive disorders, anxiety disorders, trauma disorders. So if folks are really, really motivated to do the work that he's talking about, the gains are so much richer and so much more long lasting than the gains from medicine for in a lot of ways. And again, sometimes they're like, they're partners in crime, I suppose. They're tools that we can use together. Sometimes medicine can be like the thing that lowers the symptom burden just enough that you can do that work. And if that's the purpose of me giving you medicine, is so that you can access a lot of the things that you've been trying to avoid or the emotions that are too strong for you, so that then they're able to do the work he's talking about in therapy, then that's a marriage that's really worth it. So always worth having a conversation with whoever your professional is of choice, whether that's you're accessing a therapist, a psychologist, a psychiatrist, your primary care doctor, your oncologist, about like, what's the right treatment thing for me? What does the evidence show us? What does the research show us about using medicine, using psychotherapy, using them in combination? And then what am I able to do? What tools can I use that are accessible to me and that are likely to put me in the best position to be able to like be my best self, the best version of myself. So that's my spiel about that. And I'll stop talking. Oh yeah.
I have a quick question, and particularly in the African American community, because often that community will not seek help. How do you encourage someone who's received a diagnosis, or you see that is depressed, to seek help? What would you suggest as a way to encourage them that they don't have to live that way, that there's help and support, but because of past history, what they heard about, that they were reluctant to know?
I'll answer because I'm in the space. How there are a lot of, nuances in that question and in ways in which we can answer it. What I've seen is really building my community. I think that in my years of practice, if just what we might think is a very basic thing like community, when that is built, people feel safer to open up and kind of express what's going on. I've had clients sometimes for years, they'll stop, they'll come back, and maybe year two, they disclose to me that they've had some type of diagnosis, or they spent, a decade in jail and had a diagnosis while incarcerated and were re-traumatized over and over and over again. But they had to see me and build that relationship and know, okay, this is a safe person. This is a safe place for me to go to. This is someone safe for me to talk to. That's not evidence-based. We can't pull a report or, any scholarly literature around that. I think it really just kind of boils down to we heal in community. And that is what this is right here. And I think kind of getting that message out, however we do it, really breaks out some of those barriers. I can talk to, we've studied, we've done all the things, but if someone comes to my office and, Dr. Timbo, this is what's happening with me, and I pull out, some words, well, the literature says, they're like, oh, now I'm not going back to her because she can't relate to me, or I'm like a very human, what we consider basic level, but it's not so basic. And I think that opens, the door to allowing us to just be ourselves and allowing people to see the humanness in us as well. We just had done another thing. We just studied in another area, but, as people, as humans who've also power on lived experiences, I think it makes it real. And then people feel safe. And then, that can open up some of the doors. I've had tons of clients say, well, I want to see another clinician of color. I always explain, sometimes it's not necessarily that, that allows things to be brought in for you. It is the human connection. And maybe the clinician of color just allowed you to see the human connection. Now you can go out and, join other programs and be part of other groups and get that same human connection. No scholarly answer for you, but a real answer. I will share what she said is actually incredibly scholarly. So one of the single most important, like if you look at all psychiatric illnesses and what's the likelihood people are going to recover, their symptoms are going to improve, they're going to go into remission or at least symptom stability. The number one most important metric, the number one most important thing to look at in treatment to gauge success is, do they keep coming back? It's not what medicine we prescribe them. It's not what type of psychotherapy we use or the modality or the treatment modality. It's, do they keep coming back? Do they trust the person that is providing their treatment? So not to say that we should provide treatment that doesn't have any basis in science, because we certainly should not do that to our patients. And I'm not advocating for that, but it is all about the relationship. So I think that's incredibly scholarly. It's supported by research. Like if folks trust us and they keep coming back, we're more likely to do well.
100%. So I remember it's then early on doing therapy with kids, or I'd say to my therapist, my clinical supervisor, I'm just sitting there playing games with them and we're just talking about something like he said, you remind me, relationship. The relationship of 101, that's the first thing we want. Get people, heal people when they are connect at the heart level and they trust.
I'm just going to give the most social working answer of them all. Remove any barrier or access issue to services as possible. Sometimes people are a little surprised that through family hospice, my client population is pretty representative of the territory I cover, which my territory is the city, north of the city, out to sort of Cranberry, Wexford, out to Jeanette, Irwin. So I have a very diverse population in every sense of the word, and my client population is very representative of all of that. And I think it's because our services are free. Our services do not require insurance. We reach out to folks
we are welcoming. And so just at the most basic level, making it easy for people to take advantage of the services they deserve to have and encouraging them to do that. Our services are also, they go for 13 months for the time of death. And so we don't require that in sign up, the first time we speak to them. They're welcome to call anytime within those 13 months. And if they call outside of the 13 months, we do our best to help them find other resources of support. But that would be my answer is limit barriers or get rid of barriers.
Mine's quite key. So one of my very good friends from doing all this work is an young adult African-American breast cancer survivor. So from time to time, I'll pick her brain. What do you think will work? And she's like, we don't want support. Like, we just know if there's a support group word, we're not attracted to that. So sometimes it's getting creative of you eliminate the word support. I'm not saying it with everything, but sometimes you just have to get a little bit of creative. Like when you said sister circle, I was like, I love that. Because it's not just typical support group. Because then they come and expect something else, and you may then talk about it and include food or include an activity. But it's not just a direct support group, because then they're like, I don't need it. I don't go that. I'll pray instead, right? So I just wanted to note that sometimes we also do it too. Like we have these socials, and it is kind of a support group sometimes. They're doing a craft with it, but it's still support. And same thing with Kids and Bridges with all the other activities. So it could be a wellness thing, but include that supportive discussion too. So sometimes just getting creative, but it helps it.
I roll in full transparency. This is wonderful. Typically, in a lot of Black communities, this is not necessarily a thing. And we're all over talking about, you have to make resources accessible. So I do a lot of study around the strong Black woman phenomenon. But when I do my research looking at the strong Black woman phenomenon, it's not just Black women, it's women. And a lot of those things are highlighted in how women are coming through our lived experiences. And we commune in the kitchen, we talk, we eat, and we say, okay, that was good. Now I want to go home. How can we recreate those types of experiences in community? And when we talk about barriers to resources, I really do find, in a lot of the community I'm part of and a lot of the community I serve, there are a ton of barriers. Sometimes it's just transportation. And, there are some outstanding service in the Wexford. Maybe some of us can't get to Wexford. Maybe some of those things are right kind of where we are. So it really warmed my heart to hear trying to move those services out of that community and have multiple of you, in other places. Because if I can walk, and if also maybe free or low cost, maybe I can bring my kids. I'm sick, I'm not well, but I still have to care for these children. I can bring them and they can have services as well. Maybe I can't talk and someone can work on my body. I think that would definitely bridge a gap, make things more accessible for others.
Okay, we tap a few more questions. It's really close to the.
Hop really allowed her to.
What easy.
Watch plus assembly. Yeah.
Kiss.
I just wanted to. I picked one for this from year. At my birth treatment, strictly be human. It was awful. I didn't know who I was, where I was. Spot treatment as it, and I started making it was a little bit easier. But I don't know if any of you have ever hit rock bottom. That happened to me a couple months ago. I fell, I broke my ribs. Had I ended up going to the hospital a week later, I never would let me come home, and I said, please keep me. Please. I needed a reboot. And it wasn't even the ribs. It's more here. And I said, I don't want it the whole. I need help. And it's all. And I had Wendy as my therapist, and she helped me through a lot of it too. But it's just so scary when you get, like, I was isolating, and, there's other battles involved with family and stuff like that. But that's what I needed at the time. And those 2 days in the hospital, palliative care came in, up to PT, and they qualified for those. They're like, here's a cane, so you don't fall. And
You're saying sometimes we need more support.
yeah,
And we are deeply empowered to ask for it. And you went ahead and asked for it.
yeah. And I need to try other things too, because I'm so interested in your services. I've been with out that way. So I'm open to doing other things, but when you're metastatic, like, God bless you, 14 years. I don't know what's gonna happen, but I'm just glad that you all were here. And you were good. We saw. So you call because I'm scared. I'll die. I have to branch up into what and I want to be around to now. And I'm 63 and so close to hair. How many people at 63 but the hair? I hate you so, but I love you all, so thank you.
I don't have a simple answer or response to that, but I felt compelled to, kind of grab the mic. I think cancer changes you, right? Like, you hit rock bottom, it changes your life completely. You go through all these different phases. It's such a big change. A lot of the work I do is patient centers around like your core values. And in my clinical experience, generally speaking, people's core values, the things you care most about, a lot of times do not change because of cancer. For some people, they do. Certainly, and your priorities shift a little bit. In my daily practice, though, in the therapy room, your core values, what you care most deeply about, a lot of times remains very stable. Family, children, grandkids, your health, your spirituality, your community, right? So when people are at rock bottom with me in therapy, I try to fall back on, like, what do you really want out of life? What really matters to you? And what is the smallest step, the smallest action you can take that moves you towards your values? And this could be something as simple as maybe you're in like a rehab unit or whatever in the hospital. Can you FaceTime your grandson? Can you at least do something that moves you towards a larger purpose that connects you with what really matters to you? And the really cool thing is we all have the opportunity to do that right now in this moment. It doesn't matter what your future holds. It doesn't matter what happened in the past. You have a choice right now to do something that matters to you deep down in your heart and to give you a great sense of purpose, fulfillment, enrichment for life, even if it's the smallest step. And sometimes if people are rock bottom, just start taking some baby steps, small little actions you can take. And then those become these like larger habits, larger patterns. It's almost like it's like upward momentum to help you kind of crawl out of that rock bottom. That was one thought I had. I don't know if that helps, but I think especially when people are dealing with things like metastatic disease, you're confronting your own mortality. That's what I always fall back on, is like, what do you really want out of life? What really matters to you in your heart deep down? And how do we get you to connect with that at a deeper level so you live a life of purpose? Someone said quality over quantity. Forgive me, I forget who, but that's kind of speaking to that. Hopefully that helps at least give a little bit of perspective.
I want to chime in just a little bit. First, I want to thank you for sharing probably some Fox feelings that a lot of people in this room or maybe on Zoom or feeling. It takes a lot of courage to be able to talk about that. So thank you for sharing with us. In the same vein, I wanted to just also suggest that there is a what they call a manualized treatment. And all that means is that it's a very specific set of sessions, the summit sessions. It's a therapy called meaning-centered psychotherapy, which is very, very short what he was getting at. And it was developed by the folks at Memorial Sloan Kettering Cancer Center for folks with advanced cancer. It's very, very specific. You have 7 courses of 7 sessions, I should say. And you could do other therapies in addition to that. It's not like I pay 7 and that's all you get. Talk therapy is often very helpful in coordination with meaning-centered psychotherapy. I just wanted to put the name of that protocol out there because it is something specifically that you could look for to help find that meaning and purpose in yourself, in your life, and sort of tapping back into who you are at your core, that beautiful person that you were, and that actually most people find that they continue to be. It just has gotten kind of lost. It's based on, Wolf and the work of Viktor Frankl. And so I would suggest that might be something very, very helpful for folks who are having similar feelings. It's called meaning-centered psychotherapy. Well, can I add to that really quick, just to your point? And I recognize there's a lot of reasons or a lot of factors that go into how easy or hard this is to do in practice. But I was just having a conversation with somebody today, and I work with a lot of metastatic patients as part of my roles at AHN. And I met somebody who would not have scored positively on any of the measures that they get at their appointments. They wouldn't have scored high at the distress screen. But this is someone who's been dealing with metastatic cancer for years now, but they're in a good place. And they came in and I said, we'll bring you in. They're like, I know there might come a time where this changes. And I wanted to make sure that I've connected with you, connected with support. And that way, if and when that happened, I haven't. I don't have to wait until I get to a point where it's like, I'm crying for help, right? And I like to believe that the oncology world is getting better at recognizing the importance of mental health in cancer care, as evidenced by, Anra and I will work in the health system, as well as Dr. Balby, who works at the Hillman Cancer Center. But we certainly do still have a lot of work to do. But I usually will empower and advocate for my patients, which sometimes by the time they get to me, it's, I don't want to say too late, but I will usually encourage people, if you need help, ask for it. Whether it's for mental health support, whether it's support at home, whether it's transportation, whatever it is, ask. And if you get met with barriers, ask again. Ask somebody else. Because even if one person doesn't know who to connect you with, somebody else might. My work with getting people to advocate for themselves is to hopefully avoid them getting to a point where they're like, I'm tapped out, I have nothing left to give. Because you're already going to the lolly. I'll watch it get to a point where it feels like it's overwhelming. And so I heard you again, I recognize it's easier said than done, but ask for help if you need it, whether it's mental health or otherwise, to hopefully prevent it from getting to that point. And thank you for sharing your vulnerability there.
I think we each have one very quick question, and you must hold the mic back.
Thanks. I'll try to keep this quick. I'd like to get your opinion on the forgotten patients, the particular challenges faced by forgotten patients, the caregivers. We see what the patient is going through with the physical and emotional mental health. By the way, chemo brain gets contagious. But we have our own issues, plus the issues of supporting the cancer patient as well, both their psychological, emotional, physical stuff onto that. Could you address some of the particular challenges that the forgotten patients, the caregivers face?
I'll say some brief words about that. Wonderful question. I would agree with you so much that I think the caregivers are forgotten about, but not on purpose. We still love you so much. But I think that it's difficult for caregivers sometimes to ask for help because they are so entrenched in caring for
Guilty.
and guilty. Yeah, saying, I need help. I need, some respite services. I need the meal. I want to just kind of, I think collectively we all said it's okay to ask for help. No one is judging. That's what we're here for. And I know sometimes from the inside, that's something that people have to work towards. Now, what I do as a clinician, as a caregiver myself, my mom's a caregiver, there are several diagnoses in my family where people are not getting better. So we all kind of do things in this caregiver role. So what I typically do is I don't ask the person if they necessarily need help from me. I just look at the basic things we all need: food, water, maybe a kiss. I don't know, whatever. I'm all for you get a kiss, but food, definitely food. But we need food. We need water. Sometimes we need a gentle touch, just a pat on the back or something like that. I just kind of get those things because, I'm in this space. I know that those are some things that might be needed, but definitely ask for that help. I had a lot of caregivers that come to my practice. They've never come and say, caregiver, this is why I'm calling out for help. They'll say things like, people that I work with at my job, getting on my nerves. I guess to talk about career. But once we kind of dig a little deeper, it's not work. It's a type of work. It's a type of caring for another, and we're able to kind of to get at that. But I think first step for you said something out loud. I'm popping again, kind of receiving some feedback.
Can I give a quick answer? I know we're short on time. In my experience, the patient and the caregiver are going through two totally very different things, but fundamentally, like at the core, on like an emotional level, you guys are going through like very similar things: anxiety, sadness, guilt, worry, stress. Certainly maybe some of the physical symptoms are different, but I think I very like human level. Someone said that here. A lot of times people are actually feeling these same exact emotions. And I hear all the time from my patients, if you don't have cancer, you don't understand. I'm seeing some head shake. So I'll ask my patients, well, have you told them how you're feeling? Well, then how are they supposed to understand? My simple answer is, can you guys just start talking about it? I encourage my patients and their spouses and their caregivers all the time, stop talking about the logistics. When's your treatment? What time's? No, stop. How are you feeling? How are you doing? What's going through your mind? What are you feeling right now? Can you have like a 10-minute like state of the household where you just check in with each other or how you're feeling, and to pull all of this together? It humanizes all of us. It's the human connection. You're connecting with other people. And I think that is such a bonding experience for caregivers as well as patients, that I think if you look past all the logistics and details, fundamentally, deep down, you guys are probably going through a lot of the similar emotions and feelings and thoughts. And I forget who said it, but they had a great quote about love here, about like, that's an opportunity to love. Right? You said it, Wendy, right? Sharing some of these things, talking about it and getting the support is an opportunity to build that connection. Just talk.
Just super fast. I read it's the only study about this that I've read, that I've seen. So this is an under-researched area, I think. But the statistic that I read was that the caregiver patient burden and stress burden is approximately 50-50. And people are always surprised about that. But I've seen it play out where we used to have the brain tumor group in person or at the other location. Folks with brain tumors often need some help driving. So those upper caregivers was often there. And then you would see this dynamic. The person who is the patient often feels that they're a burden, or maybe even that their symptoms are might be embarrassing to a caretaker or et cetera, et cetera, et cetera. Where the caretaker worries about what is the person who is moving through this treatment, what are they feeling, what are they thinking? And you can just see this disconnect, or if we can get that dialogue to open up, that burden can be shared. And when we share our burden, it becomes much more bearable. So that's me. I agree very much with what Jan just said.
Wow, we could probably stay here for a lot longer because, as you see, we all love what we do, and you all have a lot of questions. So I want to just say this is just starting the conversation, right? So we will have certainly a lot more, I think, panels on mental health. And, I did read a statistic actually about caregivers, Kurt, that 40% of them actually have, that are taking care of a loved one with cancer, have some type of anxiety or depression. So that's a pretty high number, right?
It's low.
Yeah, well, you're probably right. You're probably right. But even that is hot, right? So anyway, I want to stop and thank my rock stars, and for this amazing. I want to thank them for their time, their passion, and their talent this evening, as well as the time they spent, meeting on Zoom. I mean, none of us usually take lunches. We all should, but everybody was there, and I just want to thank you guys from the bottom of my heart. I also want to thank Kyle Jennings here with Steel City Visuals. He is a good friend. I've known him since he's this high. Played soccer with my son. And I thought you needed his help here because we wanted to capture this in a really clean way. And you all have been on my Zooms, and you know that I'm not really great at it, and I'm putting my poor staff, in editing. So Kyle's promised me a nice clean edit. So thank you. And then also my staff. I mean, we are a passionate web of the soul. Love it. So thank you for my graduate students sitting back there. Thank heaven for our students, right? She's helping with the Zoom tonight, so it's all good. So I want to end on this, and this is probably when I first got into cancer care, right back at St. Francis Medical Center many years ago. I really wanted to work in peds, no jobs at Children's, so I had to pay my student loans. They put me on the oncology unit at St. Francis Medical Center, and I, like these guys, kind of fell in love with the whole thing, right? And so it was really important. But this poem was given to me a long time ago, and I thought, what am I going to say at the end here? I wanted something, and I started out with hope, right? But you guys, you did a nice segue for me, thank you. And what cancer cannot do, right? What we have control over, what our values are, what our sense of purpose is. So I'm going to read this, and you all probably know this, right? Because it gets at the core values of what we are, right? And value exercise I do with a lot of people. So here we go. What cancer cannot do. It cannot cripple love. It cannot shatter hope. It cannot corrode faith. It cannot destroy peace. It cannot kill friendship. It cannot suppress memories. It cannot silence courage. It cannot invade the soul. It cannot steal eternal life. And it cannot conquer the spirit. So hold on to that, right? Because that is what value and purpose in your life is about. And that can be found in every day of your life. So thank you again for coming out. You guys have been an amazing audience online as well as here. And we hope to have many more of these. And if you need us, we're all here. Just ask. And